Then we are at the item that all of you are here for, I believe, which is the fiscal year 26-27 and 27-28 budget. And we have Director Tsai, Drew Murrell, who's our CFO, and Emily Gibbs, who's our Deputy Finance Officer for Budget and Planning. I believe are all here, and they will probably give the report together. Do you want to start, Director Tsai?
Thank you. Good afternoon to the Commission and to everybody that's here. I know there are quite a number of folks outside that are not able to hear this since there was no overflow space available, but I appreciate them being here as well. The subject of our, just for context, is of this agenda item is reviewing in front of the Health Commission additional budget items that DPH has had to propose with respect to our upcoming 2-year budget cycle. I will walk through the context of that. There's a set of things on our FTEs, and there's a set of things on our contracts with community-based organizations. I am appreciative of how many folks have, but I see many of my staff here, as well as others in the community, clients and patients of ours. I want to thank folks for being here. It's a very difficult time. I can promise you that neither myself nor anybody on the DPH team has been enjoying our lives much recently with very difficult decisions we have been needing to work through. We're all in public service, and we're at the DPH because we fundamentally believe in public health and public sector and public services, and being the safety net to San Francisco. And so I will walk through some of where we are on the budget, including a very significant amount of funding that we have been pounding the table for that we are getting to offset terrible cuts to Medicaid. That does not, though, make any of the cuts that we are talking about any easier, and I respect that, and I'm glad you're all here. So allow me time to walk through, as we had committed to in front of the Commission, where we are on the budget. So I believe there are slides that we will bring up.
It's here. And just SFGov TV, please pop this up on the SFGov site. And I'm going to keep using my PC until you do that. And Director Tsai, please continue.
So I'm going to walk through some context. Some of this was at the last Health Commission meeting that we presented the initial budget at. So as background for everyone on the safety net here, certainly folks are aware of the city's budget deficit, but I want to call out that a very substantial portion of the city's deficit is not just due to local pressures, but it's fundamentally because the federal government and also the state are stepping back from their support of the safety net, particularly around Medicaid, here in California known as Medi-Cal. You'll see there's about a $300 million cut. We expect the biggest portion of that is from the federal government, what the president signed, otherwise known as H.R. 1, or the One Big Beautiful Bill Act. It cuts Medicaid across the country, and for San Francisco, for us at the DPH, it will be hundreds of millions of dollars. That is one piece. And the second is at the state level, individuals with certain immigration status, including undocumented individuals, will be losing their Medicaid. Those two cuts collectively lead to unprecedented cuts in the safety net and in Medicaid all across the country, and especially here in San Francisco. They are incredibly damaging. The past 7 months, I and others have been in discussion directly with the mayor and the mayor's team on how we as a city approach these cuts. And the biggest piece here for us has been that DPH alone cannot absorb all of these federal and state cuts. If we were alone to have to absorb that, meaning for others here, the reimbursement that we receive from Medi-Cal is being cut. People will be kicked off of Medicaid coverage based on federal and state policies. Here in San Francisco, we will continue to provide services and care for everybody, whether they are insured or not. For individuals who are kicked off of Medi-Cal based on state policies for their immigration status and other reasons of losing Medicaid, we will welcome them back to Healthy San Francisco. We at the DPH at San Francisco General Hospital and our primary care clinics and our behavioral health clinics will continue to provide care for those individuals. And unlike some other places across the country, we are not cutting back, a huge portion of our entire safety net or services at our hospital or massive layoffs as a result of that. And part of that is because other city departments in the budget, those budget numbers you've heard, will help the DPH pay for all of those very terrible, damaging Medicaid cuts. The challenge of that, though, is even as we're getting a bunch more funding and other city departments are contributing, we all don't feel that because a lot of that is, unfortunately, offsetting huge cuts in our budget from the federal and state government. I am grateful, though, for the city overall and the mayor's support in saying we're not going to let the safety net crater here in San Francisco, and DPH will receive substantially more support. And all the cuts that you guys are here to advocate for, I respect and understand because I don't diminish any of those. On the next page, just to make the numbers clear, thank you. This is what is in our budget submission. Our total budget will grow by $409 million over the next 2 years. For those in the room, our current budget in that first top right is $3.366 billion. At the end of this budget cycle in 2 years, we will be at $3.775 billion. That will be a $409 million increase. The biggest piece to what I just mentioned is if you look at that row that says general fund, and general fund means how much of DPH's budget is supported by local tax revenue. We today rely on the local tax revenue for $779 million. The reason why we're not having to fund all of the DPH through local tax revenue is because we get paid by Medi-Cal and Medicare and other health insurance. That's good. Because we're getting several $100 million of cuts from the federal government on cuts to Medicaid and also the state, you'll see in that second row, our general fund portion of the budget will grow by $307 million, from $779 million to $1.085 billion. That is a 40% increase in DPH's budget for what we rely on from local tax dollars. I say that because, on the one hand, all of us are deeply, deeply challenged right now for the budget environment and the cuts DPH has had to propose. And we've spent 7 months pounding the table and negotiating to be able to get another $300 million of additional support from the city, which other city departments will have to help fund, to offset the Trump Medicaid cuts and also state Medicaid cuts. So our budget that we proposed and put forward to the mayor's office accepts a $307 million increase, or a 40% increase in the general fund budget for DPH. Next page, please, Mark. And just on a timing piece, I'll fly through this next piece quickly to get into the actual cuts. We are now here at April 20th at the Health Commission going through. We already put in the budget that accepts the $307 million. We're grateful for those discussions. We had to do belt tightening to even get to the $307 million. Otherwise, we would have needed about $440 million extra per year from the general fund. And so we have had to do belt tightening, some of which we presented at the Health Commission earlier this year. And we had a remaining $40 million target we will talk through that we had not yet identified. Those are what we're presenting here. They will go to be transmitted along with all of your public comment to the mayor's office by the end of this month, April. The mayor's office will then consider all of those comments for what the mayor puts out for his budget on June 1st. And at June 1st, it will then go before the Board of Supervisors, and there will be much public comment and debate there, and then the board will vote towards the end of June. So that's just where we are procedurally in the overall budget timeline. On the next page, I'm not going to walk through every one of these numbers, and something in the formatting got off, so the second half of the page you can't see. But all the materials are posted online. The one thing I wanted to note about this page is our team has done everything possible to find administrative efficiencies that don't impact programs or staff. And we have committed to getting another $176 million of new revenue, meaning health plan, Medicaid, Medicare reimbursement that our team is working on. Every penny of that reduces the need for any cut. And on the next page here, we have, in order to accept that $300 million budget increase, we had a $40 million gap we still had on our budget. The direction from the mayor's office, meaning we would have needed $347 million, but we had $307 million extra. So the direction from the mayor's office was to split that half-half between internal FTE reductions and also then community-based organization contract reductions. So I'm now going to spend a few minutes talking about the organizational FTE reductions, and then I'll shift to the contract reductions, and then, Mark, I believe then we'll turn over to public comment for everybody. So first, let me shift to the FTE reductions. The long or the short of it, just to jump to the punchline, I love public service. I love my team. We are a 7,786-person strong team. I appreciate everybody that is here rallying, and that means I understand where folks are. The punchline here is we identified 120 FTE reductions through real organizational restructuring, but we were able to limit the number of layoffs we have. Every one of those layoffs still matters because they are staff on our team, but let me walk through how we got to that in a sec. So why don't we actually just, if I could ask SFGov TV to jump forward to page 16, I believe. Oh, no, not 16, 10. Backwards. Yes, this page. So I'll walk you through how we identified 120 FTEs in a sec. And all these materials are posted online, so you have the soft copy of this exact document. And it's also printed out here for anyone taking pictures if you want access to that. For the 120 FTEs, my message to everybody who has said, well, let me go through the numbers and then go through some of the feedback we've been getting. 70 of those 120, our principle was to try to minimize impact on our staff. Our staff are public servants. It's our job to do everything possible to protect them, even while we try to do fiscally responsible things, given we are accepting a budget increase of 40%, $300 extra million. In order to do that, 70 of our 120 positions, if you look at that top row, it's about 60% of our, so 70 of the 120 are vacancies that we eliminated. Now, these are not vacancies that were just sitting around that we were never going to fill. These are vacancies that someone recently retired from, and we had to do some rebalancing of workload, but it was certainly better to take a vacancy than to take an actual staff position. So that's the first piece there. The second piece was 25 positions, that second row, were things where we had to do an organizational restructuring, and we unfortunately had to eliminate somebody's role. But we are a big department. We have many vacancies that come up every single month. And so for the past few months, to the annoyance of my team, we have held off on external hires so that we would have positions internally to move our staff to. And that has a real impact, and I see some of my staff here who are here to advocate about their programs. I respect that. They do amazing work. Part of what we were trying to do in this difficult context was to not have to have layoffs, even as we made choices around that. So those 25 positions are staff of ours who are in a position the role is eliminated. They are not laid off. They will be moved to a different role in the DPH. They will maintain their job for that. That's 25. Then we had about 15 positions where we have either temporary staff who were on a short-term appointment that was ending, or certain exempt staff that are not permanent civil service, where we ended, we separated, we will be separating those individuals. That's 15. And at the end of the day, we have fewer than 10 layoffs. It's around 7 or so layoffs of the 120. If you look at how, Mark, if you can go backwards one page now, for how we got to the 120, and I will say this here, I know this room is advocating from a particular perspective, which I really respect and appreciate and thank for being here. I've gotten a lot of push from other city departments for what we at DPH are doing to manage responsibly, because we are getting, the city is stepping in, providing DPH with substantial extra funding to offset the federal and state cuts. And so I've been emphasizing, even though we're managing layoffs, it doesn't mean we've been willy-nilly. We have made, as evidenced by everyone here rallying, so anyone that wants to say the DPH didn't look hard, you all are here are evidence. We looked really hard at positions and things to restructure and make very difficult decisions. They fall into a few different categories here. About 40 of the 120 roles, again, these were not all filled roles and they're not all layoffs, but just how we got to the count. About 40 are restructuring certain analytic, administrative, and operational teams. There are about 30 roles that came from IT and HR. There were 20 roles where we had several layers of managers with either too few direct reports, where we would combine a team, or multiple layers of management before the direct care worker or direct worker staff. There were 15 staff from ending certain clinical programs that had been already discussed with staff, or programs that we had intended to start and hire people for, but given this budget context, are not hiring for. And then the last one, which many of you are here for, with great respect, I say, are clinic consolidations of 3 low-volume sites. And we will talk about those, and I believe we'll have much public comment from, I see, both DPH staff, patients, CBO advocates, others in the community. Those 3 clinic consolidations will be 2 Chippy clinics, one at Larkin and Huckleberry, our Cole Clinic, and then Southeast Mission Geriatric. And I see folks all up here in front of that, and I respect you all being here, and thank you, and I understand these are very difficult decisions, and I want to say on the record, not a single one of these things I can say my team or myself find any joy in, and these have been very difficult times and decisions around these. And just to close out, and I'm going to ask 2 folks to come up to talk through a few pieces. Mark, if you go forward one more page again, I just want to reiterate, I know folks will be advocating here around programs and impact for our mission, which is absolutely right, because that is why we all exist here. I also want to stay from a labor standpoint, because we are an employer, and I believe we have a duty to do everything possible to help protect our staff. Even as we've made many of these difficult decisions, our staff will not be laid off. They will be, we have other roles in the DPH for those individuals because of us managing our external hires. And 70 of our 100 FTE reductions will be eliminating vacancies. And so that has been really important to me and our leadership team, to minimize the impact on staff. I also respect and appreciate that many of you here are not to advocate for your own jobs, but the impact on our patients and the clients we serve. So I note that and acknowledge that that is a different thing from whether you still have a job at the DPH, but how we're achieving our mission as a department. So I'm going to do one other slide for context and then ask Dr. Cunnins and then Dr. Gregory in sequence to come up. One more page, if you don't mind, Mark, just to get a sense of the filled position reductions, including individuals who are transitioned to other parts of the DPH, of where they're coming from. About 1/3 are from admin and operations. About 50% are from the San Francisco Health Network. About 15% from the BHS, the Behavioral Health Services team, and about 2% from the Population Health Division. We also insisted as we went through this exercise that the vast majority of any impact identified on staff would be a non-direct, would not resolve in a service reduction, but we have some that we will talk through now. So I'm going to ask, with recognition these are difficult decisions, and neither of my leaders and clinicians coming up are excited about these, but I'm going to ask Dr. Cunnins, Hillary Cunnins, who leads the Behavioral Health Services team, to talk about the context for Southeast Mission Geriatric, and then Dr. Blake Gregory to come up and talk about the primary care clinics. But I would say neither of these are not folks pounding the table to say we want to cut services. These are folks saying how do we minimize the impact on our staff and patients to the greatest extent possible. So that is the very difficult context that they're in as well. So I'm going to turn it to Dr. Cunnins for the next page.
Speak. Could y'all make room? There's a couple people here and there's some empty chairs. Can y'all make room for them to make sure everyone has a seat? Thank you.
Good afternoon, commissioners, members of the public. Dr. Hillary Cunnins, Director of Behavioral Health Services, To echo what Director Sy just reviewed, this has been an extraordinarily difficult process facing very serious budget cuts. As part of our deliberative process, we made the very hard decision to consolidate several clinical sites serving a low volume of clients or patients. I'm here to speak about the first, Southeast Mission Geriatric Services. This is a clinic serving people with serious behavioral health conditions located at 3905 Mission Street, as you can see on the slide. There are about 9 full-time equivalent staff that is spread across 11 staff members. This clinical site serves approximately 200 unique total clients per year, seeing approximately 7 clients per day. Some of those visits are in person and some are via telehealth, so not in the physical clinical space. We are proposing the closure of this clinic, but the consolidation of its services into other nearby clinical sites. Every one of our clients or patients will be offered and supported to transition to one of our other outpatient clinics with no gap in services, and we will offer the option of their seeing or continuing with their current healthcare or clinician wherever possible. To reiterate, there are no layoffs of clinical staff or other staff at the sites. The staff members will be transitioned to other clinical sites where there are vacancies and needs. We are proposing to end clinical services at the site at the end of August, and after there is a Bielenson hearing on May 18th as required by state law. Our teams will be actively working on the transition, knowing this is important for both staff and our patients to have sufficient time to transition to new sites of care. In comparison, just as a note, our other clinical sites that are larger have upwards of nearly 600 patients all the way up to about 1,200. So this is a smaller site than other sites, and I believe that we can look forward to incorporating both clients or patients and staff into those other sites. I'll call now my colleague, Dr. Gregory, to come up to continue.
Thank you. I'll be speaking about the proposal to consolidate the Cole and Larkin Street clinics. So these are youth clinics that are part of our CHIPPY program, the Community Health Programs for Youth. The Larkin Street Clinic is located in the Tenderloin. The Cole Street Clinic is in Haight-Ashbury. These clinics serve a sort of carved out population that is distinct from our typical primary care clinics. They serve youth ages 12 to 25. It's important to note that our CHIPPY clinics don't actually provide wraparound primary care services, so they're not a medical home with a designated PCP assigned, which is atypical. Most of our clinics are primary care medical homes that provide wraparound services. The CHIPPY clinics rather provide services that are youth-centered around contraceptive care, family planning, STI treatment, and then other sort of like urgent needs as well as psychosocial behavioral health needs for this very vulnerable population. And so I think it's just important to understand the difference between the services provided at our CHIPPY clinics versus our typical primary care clinics. And, you know, as I talk more details, I also just do want to echo Director Sy that these have been gut-wrenching decisions. And really some of the hardest things that I've had to do in my career and things that we would not be doing in ordinary times. But these are truly existential moments that we're facing and having to make incredibly hard decisions to figure out how we can support the most clients with the most impact. And the hard thing about budget decisions is that they are often zero-sum. You either cut this or you cut that. And so some of the guiding principles that Director Asai shared have to do with utilization of the services and really comparing them and benchmarking them to our other primary care clinics who serve a higher volume of patients. The other sort of guiding principle to making these decisions was centered around being able to offer reasonable alternatives for care, not a replica for what is provided at these clinics, to be clear, but reasonable alternatives in geographically close locations where clients can continue to get the services that they need. So let's talk a little bit more about the Cole and Larkin Street clinics. The proposed reduction is 5.8 FTE of staff. The volume seen at these clinics is around 8 to 9 clients seen per day. And that, when you benchmark that sort of volume and productivity compared to our other clinics, when you sort of prorate it by provider staff member, the productivity is around 25% what it is at our other wraparound primary care clinics. Unique patients per year seen at Cole is around 257. At Larkin, it's 355. And I think just to echo what Dr. Cunnins has said, similarly, we want to offer a seamless transition to other outpatient equivalent services or services that are even better resourced and more wraparound than what we're able to provide at our small Cole and Larkin Street clinics. There will be no layoffs. Staff have been reassigned to other clinics, and we're planning for a very long ramp down period of a number of months with close monitoring of utilization and assessment of impact. I think just the last thing to touch on is as we've had to make these incredibly hard decisions that are zero-sum, it's either this or that, is just to say that we desperately need resources in primary care. As of last week, we had 130 patients on a new patient wait list who are waiting to get into care, who do not have an alternative, they do not have a primary care provider, and they need services. And so these are the stakes that we're talking about, is providing the highest impact service. And it's not to say that our Cole and Larkin Street do not have an impact. They have an incredible impact, and we recognize that. And I know you're going to hear that today from the folks in the audience, and it's important that their voices be captured. So we do not at all disregard the impact and the value of the services at these clinics. They're tremendous, and it's heartbreaking to have to make these decisions. And hope you can appreciate just the incredible hardship of what we're all facing right now in these incredibly hard decisions. So thank you so much for your time.
Thank you, Drs. Cunnins and Dr. Gregory. And I just want to reemphasize, we will have lots of public comment. You will hear these are real, challenging discussions that will impact people's lives, full stop. You will hear, I'm sure, from some of the folks at that work at Larkin Street or in our Cole Street clinic, the way in which transition-age youth who are not engaged anywhere else go to these clinics, and the unique services for that model, and that is absolutely true. You will hear, I think, from some of the clients here how important the clinical relationships and services are at Southeast Mission Geriatric and having specialized clinics available for the population we serve there, and that is accurate and fair. And so I want to re-emphasize, and so I appreciate folks being here to note all those things. I want to re-emphasize these are not decisions we would be making without the budget requirement to do so, even as we accept a $300 million increase in our budget for local tax revenue to help offset the Trump Medicaid cuts and other state Medicaid cuts. around this, and part of the calculus here was how do we not have layoffs of our clinical staff, and also make sure that our clinical staff in this resource-constrained environment can be seeing as many patients as possible given how much need we have, and folks that have no option as well. But I look forward to the comments, and I thank folks for being here, and I know people will speak out very, very clearly also, and I respect that. I'm going to briefly finish on the FTE stuff, and then I will go to the CBOs. For those waiting for public
Sorry, I'm
comment.
dialing into a meeting. Health Commission.
Oh, no, someone. We have a big budget, so I apologize. There's a lot of things to go through before we get to public comment. Thank you so much for your patience here. There's a lot that we have to do and are working through on impact for staff. I won't go
I'll
through
bring
the
it back
detail.
tomorrow.
Hold on. Diltar, please mute yourself. Diltar, please mute yourself.
So I'm going to move past some of the FTE pieces now, so I can go through the contract, our reductions with our CBO partners, so we can quickly get to public comment that everyone is here for. So if we might advance, Mark, to page 16, I believe it is. It says contract reductions principles. Okay. Folks who were in prior Health Commission meetings will recognize some of these pieces, and we made some modifications. The first thing, as we have about $1 billion of our budget, our range of CBO, community-based organization contracts. In making these difficult decisions, and our CBO budget, our contract budget still grows with CBOs being community-based providers. It does grow. The cuts are around it growing less fast. We tried to prioritize contracts with demonstrated outcomes and took a look at contracts with really low volume or really, really high cost per individual served. We really wanted to make sure we can maintain investments in behavioral health treatment and getting access to services and case management, and take another look at services that don't have demonstrated success that should be over space time. On that. And we wanted to apply an equity lens to all proposed reductions. I want to note for the record, there are no cuts to the current roughly $25 million per year of the HIV General Fund backfill for San Francisco. And what that means is San Francisco has covered the reductions in Ryan White Part A, B, C funding for HIV over the past 2 decades, and that amount is at $25 million. That is fully maintained. There are documents we also have shared in full transparency for everybody for about 650 rows of all of our contracts. You can see every single contract, the contract amount, full transparency for everybody, and where the contract lines up. You will see that the vast, vast, vast majority of the services around access and even care for very marginalized, vulnerable populations are not touched around that. And we had a set of difficult decisions where we did find additional administrative service, non-service impacting pieces that required a lot of work with some of our CBO partners. So to that, I'm going to ask Drew Murrell, our CFO, to come up and walk through those.
Okay, thank you, Director Tsai. Commissioners, go through the details of the CBO portion of our savings proposal. First group here are concentrated in efficiencies and administrative reductions that result in no service reductions. I'll go through quickly, but they range from taking advantage of a recent move to Epic and an ability to reduce our reliance on Avatar, various consulting contract reductions that achieve up to $2.4 million in the second year of ongoing savings, reductions from efficiencies with UC that will result in no service reductions, further efficiencies with UCSF that true up in all cases our current contract budget to the service levels. So in instances like in optometry, there's a certain line of service that hasn't billed in the past year. This proposes to true that budget up to what we are actually incurring. And again, just to emphasize that last line also, we're looking at every place we can. This last line, the cost of doing business, is just grabbing the contracts that would have received the cost of doing business and then recognizing because we're cutting these contracts, we also have savings on the CODB. So really trying to find every bit of savings so that we can stretch our dollars the furthest to cover services. Second group here is changes to funding sources. This group, 8 of the 9 million is tied to what the state voters passed in Proposition 1 that changed the required spending categories under our Mental Health Services Act. We have to get in line with certain new categorization of that spending. Increase money for housing intervention, increase money for intensive outpatient services, FSP, and then decreased available funding for certain categories of other spending was called workforce development and other categories there. Those changes were presented at the preceding Health Commission by Dr. Cunnins. This is coming back because we wanted to credit ourselves with those savings and really recognize what the state had already forced us to do. The next category. So pursuant to the mayor's instructions in a February memo, we are proposing certain line item reductions to some of our harm reduction spending. So in the first case, we are cutting in half a supply clearinghouse that we contract through the Alliance Health program that we anticipate will be about $600,000 of savings. We also have reduced, not eliminated, but reduced the AIDS Foundation syringe cleanup project to bring it in line with what current utilization anticipates to be. Finally, transition outdoor supply distribution at 3 mobile sites away from no additional public spaces. We are transitioning those sites to reallocate the resources, working with the providers to additional treatment options and increase clinical care in indoor spaces, while maintaining core overdose prevention services. Savings there is anticipated to be about $80,000. Next category here is further reductions in low volume, underutilized services. So in one case here, we have the BART, which is a perinatal opioid treatment program, seeing about 7 clients. We will transition them to care at the same site and thereby achieve $264,000 of savings. We have the Public Health Foundation contract here. Services had already wrapped up. They've concluded as the state has gone live with a CalAIM Justice Involved benefit, both through ECM. So this recognizes some savings for services that have already concluded. And finally, a pilot program for outpatient substance use coordinators. This was an underutilized service that we found could be better done using citywide navigators that are able to access services really across multiple clinics and not have these navigators embedded in particular programs. This savings grows to be ongoing of about $1 million by the second year. And finally, in a group of additional adjustments to contract budgets, we've recognized here a 6.6% reduction across the board at 7 of our health access points, and one group of savings with a provider that is ready to bill. We think all of the providers can be brought to bill. More capacity is needed. This cut, the 6.6%, maintains our investment in the health access points above $10 million for this, what we recognize and agree as an essential, important service that we have to maintain and do better on billing. There is a reduction to our investment in the hospitality house of about 6.6%, $250,000, recognizing efficiencies we think we can achieve in partnership with the agency. A reduction to Felton, which is a program supporting contingency management program at Maria X. There will not be a change in services associated with this reduction. Services will transition to a variety of city staff as well as a additional contract program support. The reduction represents about 3.4% of $27 million of annual funding for Felton. And then finally, a reduction in partnership with RAMS to identify additional savings of about $400,000, or 1.1% of their funding budget with DPH, to identify those savings across the many programs that they administer in partnership with us. And then lastly, 2 additional categories. We have a rebasing, which essentially means we are limiting and scrutinizing every request from contracts to add funding based on prior year savings to current year contracts. This is part of the dance that we typically do around this time of year, and we are now scrutinizing that and believe we can achieve at least $1 million from really tightening our belts and identifying areas where that savings can be used towards this target. And lastly, we want to be transparent and recognize something we know is needed and coming. We've heard from some of our board and care facilities that in order to keep our people in those beds, there will be some rate adjustments needed. This $2 million is what we think is needed in order to maintain our system of care, our beds at those facilities. So we wanted to show it here and recognize that it is something that's coming and needed. Just one note, I want to reemphasize and hit again this BHSA. So if you'll reckon back, this was about $9 million of total savings in the change to funding sources category. $8 million of that came from BHSA. Those were changes enacted by the California voters, changes to what was allowable to be spent under our Prop 63 Mental Health Services Act, now called Behavioral Health Services Act. We had to do those changes as presented by Dr. Kunens at the last Health Commission. We needed to recognize the savings that was achieved as a result, and that's where the $8 million is coming from, us enacting the state-required changes. And I will turn it back to Director Tsai for the very last on.
I think the final thing on the contract side, I won't go through this detail. We've gone through with many of our CBOs. There's a lot of work we need to do together with our CBOs, some of which we own at DPH. It takes far too long for our CBOs to get paid by us, and that is not helpful to our CBO capacity. And there's a lot more we need to do to make sure we collectively can improve outcomes and data and the way we structure our contracts. But I won't get into too much of that now. So just to conclude this, and we can shift to public comment now, I hope folks can see these are not decisions we've sat here with any level of happiness or joy to try to figure out. What we are presenting before the commission and forwarding to the mayor's office at the mayor's office request are the least bad set of things we could do, especially in the context of us having pounded the table to accept $307 million of additional general fund support to DPH. Again, it doesn't mean we're getting all sorts of money to work with. It is, unfortunately, to have to backfill the Trump Medicaid cuts and other state Medicaid cuts so that we don't have to crater the entire safety net and healthcare services in San Francisco. And that's the task that our team has been working through. So I think with that, we will, I just want to say thank you all, and I appreciate folks being here. And thank you to my team who have been working through very gut-wrenching, very difficult decisions.